Welcome to our monthly Biostem Core meeting. It's very exciting to see some new faces around here, and I'm very happy with that. Today we have two speakers, Zeynep Serra Özler, who's a fifth-year medical student, and Betim İlkan Karaman, who is a third-year medical student. So Zeynep Serra will present us some new details about Scarless wound healing and the future horizons revolving around this topic. We're actually working very intensively on Scarless wound healing, and we have some studies ongoing at the time. And following this presentation, Betim İlkan Karaman will deliver us a presentation on the applications of artificial intelligence in ophthalmology and give us some very exciting examples on how AI can be useful in medical diagnosis, treatment, and etc. So yes, Zeynep, you can start with the presentation.
Thank you. I'm Sarah, and today we will discuss about scars, wound healing, and the future horizons. First of all, wound healing is the process where the body repairs damaged tissue after traumatic injuries and mostly leads to the development of scar. And what is scar? Scar is microscopic disturbance in the normal tissue architecture. When you cut your hand, it may not bother you that there will be scar tissue. You can think like it's just a cosmetic problem because it's a normal outcome in the wound healing process. But for example, after traumatic injury to soft tissue or tendon, scarring can result in loss of function or movement restrictions. And in cornea, scarring limits visual acuity, and when cardiac myocytes is affected by scarring, arrhythmia may occur. Does scarring always occur? No, it's not. Adult skins won't heal by scarring, but there are exceptions. Like in adults, bone, oral mucosa, and hepatic tissue are capable of partial regeneration. They heal without fibrosis. And different animals like lizards, such as lizards, can heal without scarring because they perform regenerative healing. And also, the fetus version of us did not scar. Before discussing scarless wound healing in the fetus, I would like to briefly talk about the wound healing in adults, it's normal wound healing. And like I said, adult skin wounds heal by scarring, and it consists of four overlapping stages: hemostasis, inflammation, proliferation, and remodeling. The first step of the wound healing is hemostasis. Platelets aggregate in around the affected tissue to form a fibrin-rich clot, and it prevents the further blood loss. Platelets release growth factors and pro-inflammatory cytokines such as TGF-beta 1 and platelet-derived growth factor. And in the inflammation phase, neutrophils and macrophages respond to chemotactic signals, and they become phagocytic and engulf the dead tissue and also bacteria or viruses. In proliferative phase, there is a reepithelialization of the wound, as well as a neurovascularization and granulation tissue formation. Fibroblasts are the predominant cells in this phase, and they also produce collagen and extracellular matrix proteins. These components provide a scaffold for other processes and wound healing. And finally, in the remodeling phase, a contraction of the wound occurs and scar tissue is formed. During this period, fibroblast transforms to myofibroblasts that aid the wound contraction, and several growth factors such as TGF-beta and PDGF, also matrix metalloproteinases, regulate the wound contraction and help to remodeling. And also immature collagen 3 converted to collagen 1. Whereas adult wounds heal with fibrosis tissue, fetal skin wounds with scarlessly. Fetal wound healing has been regarded as key model for scarless healing, and in fetal mammals, the ability to repair wounds scarlessly is age-dependent. Scarring often wounds begins at approximately 24th weeks of gestation. Wound healing does not follow fetal wound healing does not follow four steps like adult wound healing, and the exact mechanism is still unknown. For this reason, I will not be able to explain fetal wound healing due to step by step, and I will talk about the differences between the fetal wounds and adult wounds. They are thought to be due to differences between inflammatory response, cellular mediators, extracellular matrix, gene expression, and stem cell functions. First, these scarless wounds are characterized by relative lack of an inflammation, and the attenuated inflammatory response is a result of decreased recruitment, not an intrinsic deficiency of the cells. And the fetal wounds have a lower amount of neutrophils, macrophages, and mast cells. This lack of neutrophils in early wounds, early fetal wounds, is also associated with low levels of pro-inflammatory cytokines and chemicals, such as interleukin 6 and TNF alpha. And there is increased levels of anti-inflammatory cytokines, such as interleukin 10. And these mast cells before 24 weeks of gestation have much smaller mast cell granules, which contain lower levels of pro-inflammatory cytokines. And fetal platelets produce less PDGF, TGF beta 1, and TGF beta 2 than their adult counterparts. Cytokines, which regulates inflammation, also have a characteristic profiles in fetal wounds. Pro-inflammatory cytokines are decreased, and anti-inflammatory cytokines are increased in the fetal wounds. And the TGF beta, there's three isoforms of TGF beta, 1, 2, and 3, and they involve all steps of the wound repair process and have a divergent effects on scar formation. In injured fetal epidermis contains a greater amount of TGF beta 3 and less TGF beta 1 and beta 2. TGF beta 1 and beta 2 have generally been thought to be profibrotic, and TGF beta 3 is known as antifibrotic. Scarring healing has an increased VEGF, vascular endothelial growth factor expression than what is observed in late wounds in fetuses. And platelet-derived growth factor has been identified as a profibrotic growth factor. But this growth factor is virtually absent in embryonic wounds. The extracellular matrix plays an important role in cell adhesion, differentiation, and proliferation. This matrix has a dynamic layers of collagen, glucosaminoglykans, proteoglycans, and adhesion proteins. And the characteristic type 3 collagen and hyaluronan-rich extracellular matrix are key components of the fetal scarless wound healing. And don't forget them. Type 3 collagen and hyaluronic acid are essential. And there are phenotypic differences between the collagen content and cross-linking patterns in fetal and adult ones. Type 1 collagen is predominant in adult ones. This provides tissues to regenerate with greater strength and stiffness, but can inhibit the cellular migration and regeneration. And fetal fibroblasts synthesize more type 3 collagen than type 1 collagen. Also, type 1 collagen is found more in rigid tissues than type 3 collagen is found more in elastic tissues. Collagen content of the extracellular matrix changes as the fetus ages, starting with relatively high type 3 collagen in fetal ones and shifting to type 1 collagen predominated in adult phenotype. And hyaluronic acid is a glucosaminoglykans of the extracellular matrix. In general, fetal skin contains more hyaluronic acid, and fetal fibroblasts express more hyaluronic acid receptors. Increased fetal hyaluronan also prevents the myofibroblast differentiation by increasing the expression of TGF beta 3 and decrease of TGF beta 1, which is pro-fibrotic. And levels of decorin, they are proteoglycans, decorin, and fibromodulin. They are modulator of collagen fibrinogenesis. They are down-regulated. Decorin is down-regulated in the fetal ones. Conversely, fibromodulin is up-regulated in the fetal ones. In addition, the amounts of some adhesion proteins such as tenascin and fibronectin are higher in the fetal ones, and they support the cell attraction and migration. There are also matrix metalloproteinases and tissue-derived inhibitors. They are involved in extracellular matrix turnover, and Scarless fetal wounds have a higher ratio of MMP to TIMP, which favors remodeling of over accumulation of collagen. Also, gene expression profiles of scarless fetal wounds also different. Scarless fetal wound healing is characterized by rapid upregulation of groups of genes involved in cell growth and proliferation, which likely contributes to rapid wound closure. And these genes are important for DNA transcription, DNA repair, cell cycle, and protein homeostasis. Multiple pluripotent stem cells have been proposed to play an important role in fetal wound healing, including epithelial stem cells, mesenchymal stem cells, and small dot cells. These small dot cells are newly discovered cells. Epidermal stem cells migrate following injury and proceed to differentiate into dermal, vascular, and neuronal components. Mesenchymal stem cells have been shown to have a role in regenerative healing, including immunomodulation and antifibrosis, and those cells are located in blood. They specifically migrate in wounds and differentiate into dermal cells, and they release less collagen and they reduce scarring. Here's a summary of what I talked about. In fetal healing, there is a decreased levels of TGF-beta 1 and increased levels of collagen type 3. And also collagen organization is much more okay. And let's take a look at current therapeutic interventions. The use of biological tissue materials like skin transplantations is the simplest way to obtain structure and function of natural extracellular matrix. And animal or human fetus donors are using as a skin transplantation materials. And also acellular fish skin is another source because acellular fish skin is very similar to human skin structure, and due to its natural extracellular matrix structure and good biological characteristics, human amniotic membrane can inhibit the expression of pro-inflammatory factors and resist fibrosis, thus inhibits the formation of scars, of course. And there are corticosteroid injections are now in therapies. Corticosteroids are anti-inflammatory medicines, as you know, and the inflammatory response is globally decreased, which secondarily decreases collagen synthesis and increases collagen degradation. But they have adverse effects, of course, corticosteroids. These effects include delayed wound healing or dermal atrophy. And there are also chemotherapeutic agents that used in uh, wound healing therapies like 5-fluorouracil and bleomycin. In adult wound healing, tension initiates a signaling cascade leading to the proliferation of local cells, typically in a symmetric pattern. And stretching the wound may be a triggering factor that leads to abnormal cell growth. It has shown that the areas with low tension, such as eyelid, heals with minimal scarring. The external cellular matrix is a 3D structure, and it has an essential components in all human tissues. Like I said, it contains collagen, hyaluronan, proteoglycan, glucose aminoglycans. These molecules interact with each other and with growth factors, cytokines, matrix degrading enzymes, and their inhibitors. And studies have demonstrated the extracellular matrix aids cellular adherence and tissue unhorning cellular signaling. Within the discovery of extracellular matrix, scaffolds mimicking the extracellular matrix targeting the wound healing have emerged at the rapid rate. The most basic extracellular matrix scaffolds are made of single extracellular matrix compounds such as collagen or elastin, fibronectin, etc. And there are also another therapies are negative pressure wound therapy, cryotherapy, and laser therapy are used. And let's look at the future therapeutic interventions. One primary goal of the studies is determine which types of interactions promote and which types of interactions are inhibits the tissue regeneration. And therefore, let me give you a quick reminder. There is a predominance of type 3 collagen in fetal wound healing, and there is a higher ratio of collagen 3 to 1. and there is more hyaluronic acid in the fetal wound healing and high levels of TGF-beta 3. But in the adult wound healing, there is high levels of TGF-beta 1 and 2, and also there is a predominance of type 1 collagen, and high inflammatory response occurs in adult wound healing. As mentioned earlier, targeting individual cell-signing molecules has not translated effective into clinical treatments, and different types of approaches may be used to increase pro-regenerative extracellular matrix levels in the wounded area, including direct application of the matrix molecules themselves or biomaterial modification to mimic the extracellular matrix. And there's various matrix scaffolds could be combined with growth factors that promote healing, and using the matrix molecules to deliver growth factor more effectively to the wound. Using biomaterials that allowing growth factors release over a relatively long period to promote more effective healing. And in trying to promote regeneration, we can cause excessive accumulation of extracellular matrix, and it is also necessary to prevent events such as scar formation, including fibrosis and contraction. And during the adult healing process, these scar-associated processes are primarily controlled by myofibroblasts, but which is largely absent in the fetal wounds. Therefore, inhibition of myofibroblast differentiational function with low TGF-beta 1 or interleukin 6 may facilitate a stronger regenerative response. Briefly, manipulation of specific cell extracellular matrix interactions has high potential for promoting a regenerative processes. And before talking about stem cells, I would like to talk about the basic issue. One of the primary differences between fetal and adult wounds are being the niche and its composition itself. For instance, it has been observed that in early gestational cells modify the environmental embryonic niche to promote regeneration during wound healing. However, in late gestational cells are restricted to repetitive healing. Instead, they are capable of modulating the fibroblasts, and they increase the proliferation of migration of fibroblasts. And stem cell therapies is a promising approach to regenerative repair, and in consequence of the ability to differentiate cells into various necessary cell types. Stem cells are also known to modulate the wound environment and improve healing by reducing inflammation. And there's four types of stem cells can be mentioned here: embryonic, epidermal, mesenchymal, and induced pluripotent stem cells. Embryonic stem cells that have unlimited self-renewal ability, but they remain experimental due to immune system, teratoma risk, and ethical issues, of course. Mesenchymal stem cells that can be isolated from bone and nerve and adipose tissue, and they can differentiate to mesenchymal lineages such as cartilage, fat, muscle, and bone. And these cells could be isolated from an adult, then manipulated and translated back in the same patient. Therefore, the use of mesenchymal stem cells avoid the immune system obstacles. And epidermal stem cells, which have a high capacity for self-renewal like embryonic stem cells, and they characterize as interfollicular epidermal stem cells and pale follicle bulge region stem cells. And lastly, IPSS induced pluripotent stem cells, which produce by reprogramming of somatic cells using a specific combination of retroviruses, mediated transcription factors, and using similar processes, human cells may be transformed directly into functional differentiated cell types, such as neurons or cardiac myocytes or endothelial cells. However, due to use of viral vectors, there are concerns about mutagenesis and uncontrolled genome modifications. Also, reprogramming factors have been shown to be oncogenic when they are overexpressed. And in fetal wound healing, tissue engineering therapies aim to facilitate the natural healing processes by providing structural support and promoting cell migration, proliferation, and modulating the immune response. Biomaterials and scaffolds play a crucial role in these therapies by serving as a platform for cell attachment, growth factor delivery, or tissue regeneration. Various methods are available for introduction of stem cells, like IV injections, local injections. But when you inject the cells into the tissue, they have low survival rate in the tissue. And it has been proven that seeding stem cells into scaffolds and then transplanting them in the wound area amplifies the wound healing by enhancing their delivery and therapeutic effects. And there are different types of scaffolds. And decellular tissue scaffolds retain the native tissue architecture and composition while removing cellular components and making them suitable scaffolds for tissue engineering. Decellularized amniotic membrane or placental tissue scaffolds can be given as an example. And decellularized amniotic membrane scaffolds have effective properties in wound healing, including anti-inflammatory, antifibrotic, and immunomodulatory effects. And extracellular matrix scaffolds derived from natural or synthetic materials can provide a supportive framework for cell attachment, proliferation, and differentiation. These scaffolds can be engineered to mimic the native tissue environment and facilitate the wound healing process. In this tissue engineered therapy, decellularized amniotic membrane scaffolds are seeded with mesenchymal stem cells prior to implantation into fetal wound site, and the mesenchymal stem cells adhere to the extracellular matrix scaffolds and proliferate within the microenvironment provided by scaffold. Once implanted, seeded mesenchymal stem cells contribute to tissue repair and regeneration. And the last of all, hydrogel based therapies are can promising. Hydrogels are three-dimensional networks synthesized by cross-linking water-soluble polymers, and they possess properties similar to the extracellular matrix, and they can provide a supportive environment for cell growth and tissue regeneration or proliferation. And in fetal wound healing, injectable hydrogels can be delivered directly into the wound site using minimally invasive techniques, and these hydrogels can be loaded with growth factors. One of the critical problems associated with stem cell therapy is acute death of the stem cells and low retention of delivered cells at the transplantation site, which is wound in our time, which can hinder or delay the wound healing mechanism. Besides, there are also factors such as the shear stress, absence of cell adhesive ligands, or oxidative stress, inflammation, etc. In such a scenario, the delivery of the cells with hydrogel precursors can reduce the mechanical forces experienced during cell delivery. And not only that, but they can also act as a protective barriers to protect attacks from the immune system and prevent cell damage from reactive oxygen radications. And moreover, the encapsulation strategy of stem cells aggregates with the biomaterials can prevent leakage of the cell suspension at the injection site. Furthermore, it enhances the survival and retention of delivered cells. Thank you so much for your attention.